So good evening, everyone. Thank you so much for joining us. Taylor and Katerina, thank you for helping organize this as part of Michigan ACC. Today, we are going to have a very casual fireside chat with four very, very accomplished colleagues of mine who are my friends. And they span the breadth from preventive cardiology, heart failure, interventional, and EP. The intention today is to really discuss how to handle complications, not necessarily the didactic part of it, but more the real life tangible aspects of it. So with that, I would love for each of our panelists to introduce themselves and briefly discuss the most striking complication that they have had in their career. So Ilana, maybe you could go first.
You
You're
want
on
me to
mute.
start? Okay. Hi, everybody. I am Alana Katinsky. I work with Dr. Maida and Dr. Shanayan at Corewell Health, and I am a electrophysiologist. I've been at Beaumont for 20 years, and let's see, my training was at Michigan State and then University of Colorado, and then came to Beaumont. So 20 years of EP, there's been, you always remember, I think, your most recent complication. And so I was thinking about which complication to go over. But I think that the most recent one that was hardest for me was a case of a patient who I had been taking care of for a long time, a young female, relatively young, 60 years old. I'd been taking care of her for probably 16, 17 years. She had apical hypertrophic cardiomyopathy and had a history of ventricular tachycardia, had a defibrillator for secondary prevention, and she was having episodes of atrial fibrillation that she had gotten shocked for and that had caused her a lot of problems. So we had brought her in for an elective pulmonary vein isolation. And when I scrubbed into the case, I do majority of my cases at Corewell with fellows. So the fellow had gotten access, and then I scrubbed in for the transeptal, and he had gotten transeptal access, and then I put my intracardiac echo to the left side of the heart. As I was placing the ice over to the left side of the heart, I noticed that there was an effusion. And so we looked at the effusion, and it was sort of like a small sized effusion. So we just sort of kept an eye on it, finished the procedure. And as we were finishing the last vein, which everything went fairly, fairly typically, and finished the last vein, and patient's pressure dropped a little bit. And I looked at the cardiac border, which is always sort of my first thing to look at, and the cardiac border didn't look good. So I thought, the pressure had dropped maybe to 90 or 100. And so I asked anesthesia, and she said, yeah, I treated it. And I said, okay, well, we need to do pericardiocentesis. And we did a pericardiocentesis. The pressure came back up. We put a pigtail in, and seemed like it had been a fairly routine pericardiocentesis with a pulmonary vein isolation. It's not something that we don't see. And everything seemed to kind of continue. We reversed anticoagulation just with protamine. And my patients are fully anticoagulated on DOAC, but we don't typically do that right away. And everything seemed stable. So I went and talked to her husband and explained to her new husband of probably 9 months that there was a small complication, that we managed it, and that she was doing great. I came back to the room and they had moved her off the table, and she became and they had extubated her, and I walked in and something wasn't right, and the nurses, her pressure was dropping again, and we had so we drew off of, they had been drawing off of the pigtail that was in the pericardium, and nothing was coming out. And I said, all right, let me get in there and take a look. And I couldn't draw back from the pericardial, from the pigtail. And I realized the pigtail had clotted off. So we threw um, a probe on her, and she had, tamponade again. And so I couldn't undo the pigtail from the connector. So I ended up getting a scalpel, grabbing a scalpel, like cutting it essentially, rewiring it. And once I rewired it and drew back, I got some more blood out, and was trying to get blood out, and I just was taking blood out and taking blood out and taking blood out and taking blood out, and we had gotten to the 500 cc mark, 600 cc mark, and she was pale as a ghost, like white, and pressure wasn't coming up and the bleeding wasn't stopping. So I called for OR backup. It was probably 5 o'clock, 5:30, and the surgeon was not in the hospital. So I called and I said, I need you to come back to the hospital, because I'm still, pulling blood, pulling blood, pulling blood. And eventually I got to the point where she was dry again. And but her pressure wasn't coming back up. Then the surgeon came in and she still looked terrible, just terrible. And I realized that, I didn't know really what was going on, right? I would pull the blood out, it was clotting immediately. So I thought maybe there was like a coagulopathy going on. Her pressure wasn't coming back up. I didn't know what was going on. So the surgeon came in, and he wanted to know, kind of what was going on. And I said, I don't know. There's obviously a perforation. We reversed her. Usually it stops bleeding after about 200, 300 cc's. We are at 600 cc's, maybe 700 cc's. We called to reverse the DOAC. It was going to take about an hour to get that medication to reverse her Eliquis. And so we took her to the OR. So they took her to the OR. By the time we got to the OR, they opened her chest and they couldn't find any active bleeding, but her chest was open now. And then she went back to the SICU, and we never really knew where the bleeding was from. And she had a really, really hard postoperative course, 60-year-old woman, and now with a kind of sternotomy. And so that is what's sticking with me right now. She's having a lot of stress, post-traumatic stress. She is not doing well emotionally, psychologically. She keeps asking me why I had them crack open her chest, because she doesn't understand, if there was no bleeding when they got there, why they had to do that. So I have over and over been, kind of gone through the case, trying to figure out if I had done, if I could have prevented her going to the OR. I don't think I would change it. I think she wasn't doing well. I didn't know why she wasn't doing well. She was still bleeding. So I felt
Well,
like I had no choice but to take her to the operating room. Hi, Najib. And
hi all.
so that, it's not the worst complication I've ever had, right? It's not uh, but it's sticking with me because it's caused so much trauma to her. And I think I've had to sit with her. Every visit in the office has been an hour long, trying to get her through this, trying to reassure her that her heart is okay. She's now going to cardiac rehab, and this was for an elective procedure. So um, I think that's my most recent and worst complication lately. They never get easy. They never get easier to um, to address or to deal with afterwards. So I'm happy
Thank you.
to answer any questions.
No, thank you for sharing that. That is hard, especially when there is no cause. And I find that in the post follow up, like it becomes a circular conversation where they ask the same question, you give the same answer, and I see. I mean, it'd be let's table that, but I'd love to hear how people handle that because I find myself in a repetitive mode, but the patients really want something. Um, how about you, Marina?
Hi, everybody. My name is Marina Maraskin. I am an interventional cardiologist as of 1 month ago as an attending. So I recently graduated fellowship over at Beaumont Royal Oak, and I'm currently at McLaren in Bay City, so kind of back near where I grew up. So luckily, I'm sure I will have a complication within obviously being an attending, but the biggest one that kind of stands out to me is when I was a fellow, an interventional fellow. So I was a fellow for a couple weeks. I was working with an attending, like new, hadn't really met this attending before. We were kind of working together for the first time. And we had a patient, came in with an NSTEMI, had LAD, osteal circumflex severe disease, was turned down for bypass surgery. We were discussing the case beforehand, and he was planning to do some V-stenting, essentially. So basically trying to just stent to the ostium of both vessels and stay out of the left main. So this was like my first bifurcation, left main-ish intervention at this point. And so I wired both vessels. We ballooned both vessels. He was obviously picking the balloon sizes and things at this point, but I was very slowly moving the balloons in and out of the body. We go in with the stents, and the idea was to put both stents in at the same time, essentially. So we get both stents in. We're positioning both the stents at the ostium of the left LAD and the circumflex. And we each grab an indeflator, and we each go up, and he's kind of telling me what pressure to go to. We go up to the pressures, we deploy both stents. We're happy with the position. I just start taking the balloons back out. And as I'm taking the balloons out, he's like, "Oh, are you on the TUI?" And I was like, "No, not really." So I kind of just lift my hands away, and there's just no pressure at all. And he's like, "What's going on?" Like, there's no pressure. And so we quickly get both of the balloons out from the stents, and there's still no pressure. And he's like, "Okay, can somebody check on her?" And so somebody goes and checks on her, and she's out. She's unresponsive. She was awakened with it before the procedure. And he takes a shot, and there's a perforation in the distal left main. So we see just kind of light up the top of the pericardium from the left main, and the heart is at a complete standstill. So she went to cardiac arrest almost immediately. At that point, I'm a second week interventional fellow. I haven't even done a pericardiocentesis yet. So it was a similar, I think, to Dr. Katinski's case. It was, of course, early evening. It was probably like 5:30 at, last case of the day for some reason. And so he calls for an echo tech, and they don't have one in house. And so somebody's coming in, and I'm like, well, I can do an echo at this point. I can't really do much interventional. I can't do pericardiocentesis quickly, but I scrubbed out and did the echo real quick. He threw in a covered stent into the left main and just completely covered the circumflex artery, so stented into the LAD. We got basically coverage of the perforation with that stent, and then he did a pericardiocentesis. We were able to do CPR and get her back with an Impella as well. But she was able to leave the lab that day. She did end up passing away, I think, 2 days later, just from kind of complications and intubation and CPR and everything else. She just never really did well with it. Surprisingly, she didn't have any ST changes despite us completely covering her large, non-dominant, but large circumflex artery. I remember after that case, it's different as a fellow because I didn't really know the patient beforehand. I didn't consent the patient. I didn't meet the family. I didn't do those things. And so there's a slightly less of a connection with it, I feel like, than a patient that you've been seeing for a long time. But definitely, obviously, had stuck with me since it was so early in my career. I was kind of just like, what am I doing at that point? I remember talking to, this patient had been this attending's patient for 20 years, for a very long time. And so he was obviously shook up about it right afterwards. We were able to at least get her back and get her out of the cath lab initially. I remember talking to him a couple of days later. We had another case again together and we kind of debriefed on everything that went on. And then about a week later, I talked to a couple of my program director over at Beaumont. So it's a different attending and a couple other attendings that I was close with to kind of just go over the case and kind of see like what their thoughts were to try to learn from it the best I could, to figure out, how do you handle this? How do you prevent it? Because once it happens, obviously you can put a covered stent in, but it's obviously a big deal. So you want to prevent it the best you can. So I talked to a lot of different attendings about prevention and what we could have done differently, such as just stenting one vessel and then stenting the other instead of going up at the same time. I think was one of the things that the balloons were both hanging back into the left main. We did IVUS, we sized everything appropriately, but yeah. So I just remember kind of going over things with attendings and just trying to figure out what went wrong and how to prevent it. And since then, I've never V-stented again. It was the only time I ever have. I think V-stenting is fine, but I probably will never go up with two stents at the same time, maybe one after the other. Something that I kind of took from it. But yeah, that was my kind of one that sticks with me.
That is scary, especially early on. What I really think, and Dr. Kutinsky had discussed her case in our closed meeting, and the fact that you went and debriefed on it. My personal experience with complications is that, after a while you start doing the same cases, but once a complication happens, the amount of learning is exponential. I feel like just going through the process, it's as terrible as, as challenging as it is. I feel like I learned so many more things, and I suspect by discussing it with a bunch of people, you probably picked up on a lot of stuff.
Yeah, I felt like I did. I talked to my co-fellows, I talked to a couple of different attendings just to kind of gain insight on what happened and how to prevent it, like I said. But
yeah, and I mean, we remember discussing our case, right, Dr. Kutinsky? We also had some different takes on what can be done. How about you, Dr. Chani?
Yeah, good evening, everyone. So my name is Milena. I'm a cardiologist in the west side of the state. I'm a heart failure cardiologist with Corewell. I've been with Corewell now for 10 and a half years. And usually, as I tell my patients, I don't see healthy patients. I see very sick individuals on a daily basis. But I tell them that I have a rule. If you walk into my lab, into my clinic for TE, then I would like for you to walk out. A lot of things do happen in the ICU, in our CTCC. We have ECMOs. We do a lot of things, impellas, we adjust them, balloon pumps that we adjust when we list people for transplant. But one patient sticks with me. I knew him when I first came in because this gentleman had long-standing cardiomyopathy, several, I would say probably 10 plus years, had a few devices placed in him, ICDs, CRTs, had a bunch of wires left behind, had been on milrinone for a while, and we had gotten him through LVAD surgery. And this was my third or fourth year at Corewell. And so we used to do the heart catheterizations for them to the right heart cath to assess their pulmonary vascular resistance, they're listing for transplant. They were in and out procedures in a way. But these people come in INR 3.5, 4. He drove a Harley against our wishes, but he drove a Harley. That was his lifestyle. So he comes to the lab. He and I joke because I've known him those years that we got him through LVAD and so forth. I check out the right side of his neck where we normally do the Reihar cats, and that vein is just kind of completely scarred over. He has had so many Reihar cats. We used to do them every 3 months, a little excessive, I'd say. So I'm like, that's all right. We'll do the left side. And he's like, sure, doc. I mean, he didn't take any sedation, anything. You just got him in the lab there and he was ready for anything. Don't worry, I feel fine. As I said, I mean, he and EP can help with this, but he had a few wires in there. I mean, there were just a bunch of wires on the left side. And at that time, because his INR was 3.5, close to 4, I'm like, oh, we're going to use a micropuncture wire here. We always use ultrasound. It's standard of care. I always verify, you know, I'm venous because some of them have high CVPs and it can get a little dicey, especially with a small micropuncture. I go in there, I'm like, oh, okay, well, my wire got stuck. And that little wire that we use for micropuncture, I mean, that is a flimsy, flimsy wire. And I'm trying to adjust it a little bit. I couldn't get it. It was stuck pretty good inside those his defibrillator and ICD wires that he had in there. And I said, that's fine. I know I poked him. I know his INR is high, but his venous pressure doesn't seem high. I'll just do a new poke. I'm just going to take it out. Taking it out and taking it out, and I still keep threading it and threading it. So the whole wire came undone. I mean, it was like threading inside, and I was just unwinding it, but it was stuck inside of him. So the good news is because it was a day procedure, and I feel so lucky we are in our hospital. I mean, the vascular surgeon is right next door. We have some hybrid labs, and I'm like, call him. It was Justin Simmons that day. I'm like, please, can I have him here? I will need vascular to intervene. And I am letting the patient know, I'm like, so sorry. You cannot go home today. You're going to get a vascular procedure. And he's so kind. He's like, I'm fine, doc. It's fine. I'm not in any hurry to go home. Everything is fine. He wasn't hurting, but and I know this doesn't sound as tragic as the prior cases, but I mean, the patient had to have a vascular procedure done. He had to have the vein repaired and the wire fished out, and he did have to stay overnight and um, leave in the next day, have the anticoagulation reversed, which is quite dangerous, especially for him. He had an HVAD in place for this emergent surgery. We come to find out because I'm talking to my colleagues, and we had a batch of these wires that were a little faulty. Apparently, we had some other access issues happening the same couple of weeks with some of our fellows where the wires were coming undone. But to me, it was just, I mean, the patient did fine. The patient 10 plus years out, still riding his Harley, still doesn't want to transplant at this time, so he is hanging with his LVAD and doing fine. But just that was a little, you know, I mean, seeing that wire coming undone, and I just didn't know what was happening in there. Just felt a little uneasy, and the patient is fully awake, no sedation, hearing everything. Me calling the vascular surgeon, but that was my case. I have plenty others, you know, that I can mention because some of our procedures are done in the ICU, but this just stuck with me because I'd never experienced like just the wire coming completely undone and getting stuck in the defibrillator wires.
That sounds really scary. When I was a fellow at the VA, there was a case where a micropuncture wire broke off in the circulation. And by the time someone, I guess it was unfortunate by the time a vascular surgeon could get to the patient was a few weeks out and the wire endothelialized. in the pulmonary vessel, and I was just part of the patient. But I think your story brings up an important point, that there was signal that the batch could be a problem, and especially in everything we do, that we're so heavily dependent on equipment working well, or having that, having that. If something's not working right for me, how do I alert my colleagues in a timely manner so the rest of us can be on the lookout? Thank you for sharing that. How about you, Dr. Shanayan?
Hi, everybody. So my specialty is advanced imaging and general cardiology. So I don't have these kinds of complications to share. And I really admire all of you who do deal with complications right in the moment. However, there are some situations that are relevant for us. And I think the one thing that keeps me awake, and I've heard this from most advanced imagers, is missing things on imaging studies. And the kinds of decisions that we have to make, for instance, if you see somebody with completely normal coronary arteries and this patient has risk factors such as hyperlipidemia, then what do you do with their statins? Do you just take them off, and then do you just wait to image them a few years later? There are not really very strong data for this. And then what if they come back with an ACS in an area that was not well seen in the coronaries? So these are the kinds of things that we worry about. And in terms of missing things, about a few years ago, I was reading a CT, and I totally missed total anomalous pulmonary venous return on this patient. And he also had many other findings on the CT. He had really ectatic coronary arteries, and we thought perhaps he had Kawasaki's disease, and he had some fistula and things like that. And so we got the fellow who was reading with me and we got so engaged in all of these findings that we kind of missed these extra coronary situation. And this patient ended up going to the cath lab. And of course, the operator who did the diagnostic cath knew that there was something wrong with this, the pulmonary veins, and went back and looked at the CT and called me and said, can you take another look? And while not life-threatening, that is the kind of thing that really, just creates this kind of a bad feeling. And if I'm missing this, then what else am I missing, kind of a thing. And you start to beat yourself up. And in my experience with regard to imaging, whether it is on CT or MRI, it's not the big things that that are really of concern, because I think all of us who are in imaging, we kind of know that, okay, if there is something that I'm not able to figure out, for instance, with a cardiac MRI or with a cardiac CT, I can ask somebody. But it's those things that we don't know, we don't know. And those are the kinds of things that you miss, and you kind of learn the hard way. So that is one thing that is directly impactful in our line of work. But then there are also situations where we send patients, like I would send patients for procedures, and then when you are talking to a patient about a procedure, you are talking to them about the potential complications, and you say, well, there is a 3% chance of this blah blah or happening, and then they end up being in that 3%, and then they come back to you in the clinic, and then there is this whole thing because you're the one that's dealing with all of the follow-up questions, and it's not the physician that actually did the procedure, and you have to answer for those complications that you don't really know the nuances and the details of, um, and that becomes a delicate issue. And one such case that stands out for me, there are several, but I was just thinking about this, and it's quite an interesting story where several years ago, a patient came to me because he was referred to me by his dentist. So this guy had several teeth that needed to be extracted. And so he went to his dentist's office, and at the dentist's office, he had high blood pressure. And so they said, go see a cardiologist and get a clearance. So he came to my office, and I was taking his history and doing this whole review of systems. I asked him, like, tell me about your activity. And he too was this motorbike kind of guy. And he said, um, sometimes, actually more and more these days, I get short of breath when I'm walking up the stairs. And I said, okay, tell me about more of your symptoms. And he said, one thing that always raises a red flag for me, he said, I have, he actually reported a history of ED. I said, okay, this is all pointing to some vascular disease. So let me do a coronary CTA. And turns out he had 3-vessel disease, pretty severe disease, and went to the cath lab. And they decided, well, there's too much going on here. Let's just refer him to bypass. Now, remember, what was he coming to me for? For toothache, pretty significant toothache, right? And now we are sending him to bypass surgery. So he goes to bypass surgery, and with all this toothache still going on, and he gets like a 4-vessel bypass. And then he comes back to the office, and I send him to cardiac rehab. Okay, he still has toothache. And then while he's in cardiac rehab, he starts to have severe chest pain with ST elevations. So we rush him to the cath lab, and all his grafts are down. So within a few weeks, so this is pretty much like, the 3rd or 4th week after the surgery, all his grafts are down. And so he ends up having complex PCI, staged PCI, and meanwhile, his toothache is still going on. Okay, so finally, he comes back to me. This is now month 4 or 5 after his initial visit, furious, absolutely furious with me, saying, I came to you for a simple clearance, and you have taken me for a ride. I've had all these stupid procedures that I don't even understand why I've had all these procedures, despite explaining everything ad nauseum. And he says, I am ready to kill people because I'm in so much pain. I have to drink a pint of hard liquor every night to deal with my toothache. Now, either you clear me for this extractions and to deal with my toothache, or I'm going to get pliers and remove all my teeth. And I felt so sorry for this poor guy, right? From his point of view, he was absolutely right. He just thought he was coming to get this clearance, which of course is never a clearance. And then we just sent him on this wild goose chase, according to him. So eventually, and of course, now with all these complex PCIs, I couldn't take him off of the DAPT, and the dentist would not touch him until he came off of the DAPT. And because he had numerous extractions, it was a whole big mess. And this went on for like 8, 9 months. Finally, after about, I think he had been on DAPT for about 8 months, when I said, okay, we can just hold the Plavix if they can do it on aspirin. And I just sent him, and with all my stipulations on the clearance, and he ended up having pretty much all his teeth extracted. And I saw him like a month or 6 weeks later, and he was finally pain-free. And I thought he was going to sue me for sending him to surgery and for the failed grafts, and then to send him to PCI, and then having all this pain. But fortunately, when he came back pain-free, he was far more friendlier and was able to have a reasonable conversation about the course of events, that this was life-threatening considering what severe coronary disease he had. And he actually got me a gift at some point and said he was very sorry for his behavior, but that was a memorable history of complications of a patient. Yeah, and then there are others, but that stands out at the
It's
moment.
hard to hold your ground when patients are so upset.
Yes.
It's really hard to hold your ground. And
Yes, he was ballistic, and
yeah,
I really thought he was going to sue me.
yeah. Wow. I feel bad for both of you.
I know. But I could understand his viewpoint, but what are you going to do?
Crazy story. It always scares me when someone says, I'm so angry I can kill someone.
Yes.
That is
He was in
so
so much
terrifying.
pain. Yeah, poor guy. But I'm happy to report he's still my patient, and we're on friendly terms now that he does not have toothache. But then you can imagine, right? If somebody is in so much pain, like
Thanks, but
it's really hard for them to be reasonable.
yeah. Wow. So we only have about 10, 15 minutes more to go. I would love to have people ask questions in the box or raise their hand through the emoji. But while we wait for questions, maybe really quickly, could you all share with the audience what's the single most effective strategy for handling complications? Because complications are hard not just on us, but our team, our patients, our trainees. So, and maybe I'll go first. When I was in training, one of my attendings, he was a cowboy. He always took on different, very difficult procedures, first to take on the most challenging case. And he would have more than his share of complications, but everyone was very grateful that he took on the toughest cases. And during rounds, he shared with me that the way he handles it is he goes to church every Sunday, and at that moment he recalls the toughest cases and he has a conversation with himself, and that's his way of getting through the last week and embracing the next week. And I found that very, very helpful. And another colleague of mine told me that he keeps a memory box, because when we have a complication, it's the lowest moment. And he looked at his memory box for all the good things he did, all the good patient notes he got, or the photographs he received. I have adopted that. So I keep a little memory box of happy memories when I have a very challenging day. But I'd love to hear what you guys have as some advice for the audience or something that works for you.
I can share first. I think I look at a few things. My first thing is I truly apologize to the patient and the family. You know, just being honest that yes, we do say this happens less than this percent of the time, but that when it happens to the patient, it's 100%. So I want them to grieve. I want them to know that I'm very sorry and that I am apologizing to them. The second thing is moving on. I mean, clearly we know that our therapies, our procedures are needed, are necessary. We save lives, we help people. So we cannot go and start each case or care for any patient thinking of our lowest point. Each patient has their own chance. We're giving them a chance. We're giving them a treatment. So you have to start fresh from there. And then lastly is talking with our colleagues. You know, I had one of my colleagues did a cardiomems pulmonary artery perforation, the patient ended up on ECMO. I mean, we talk about all these cases and understand what could have been done differently. Can we help? Because we still continue to implant cardiomems, we still do the right heart caths, we still do all of these procedures. It's just we can improve and not look at one bad outcome to set the tone for the rest of the day or for all the patients that we care for.
I'd say it's preparation. Preparing, of course, preparing the patient and preparing ourselves. And for me, what has been especially useful is to admit my fault, my part in it, and to own that part of it, and also to open my or to open to their perspective, right? Because yes, there is my perspective, but from their perspective, things could have been different, or things could have been better, or whatever it may be. And I think a lot of times, this is something that one of my mentors told me when I was a fellow, that you are more likely to get into trouble with patients if they don't like you, even if you don't have complications, even if you don't have complications. But if they like you, you can do something wrong and still be in their good books. You know, and there'll be a temporary altercation, or there will be some explaining to do, but then it will eventually smooth out. And so I think cultivating this ability to see their viewpoint and to agree with that and to acknowledge that, I think is really, really important, because I think patients, first and foremost, just want to be heard. They want to be seen, and they want their problem, of course, to be acknowledged, as we all know. So there is that. And I have felt that with anything that I have missed on imaging or these kinds of things, I have learned to really slow down um, and ask for help. And it's not at all uncommon for me to ask my colleagues in imaging for their second opinion. Um, I have a go-to in radiology, an incredibly brilliant mentor for the last 20 years, that I will always turn to if there's something on the study that I am unsure of. And I don't have a problem saying I don't know. And it actually is quite useful, I think, to admit that we don't have all the answers. Yeah, so those are some of my strategies. There's one question in the chat asking, what habits do you utilize to create a calm presence of mind? And I would always vote for meditation and cultivating a perspective that is broad enough to include everybody else's opinions and not just mine in any decision making.
Yeah, I would say as well, obviously coming just out of fellowships, obviously there was a lot of different complications that occurred in fellowship that I was a part of, but when they happen, in the acute setting, obviously you just stabilize the patient. I think as somebody brought up earlier, when the patient's fully awake, sometimes it's hard because you want to tell the room what's going on, make sure the staff knows what's going on to prepare everybody. But if the patient's awake, you also don't want to terrify them. And so I think calmly just saying, what's going on, because the staff in the room and anybody that's there that's helping you needs to know, because they might not see the perforation, they might not see that the vessel went down or the dissection, but they need to know what you might be calling for to kind of prepare for helping you. Once you stabilize the patient, whichever way you need to, you may not be done with the procedure, but take a second. If the patient is stable, you have a minute to sit and think and to figure out your next steps and talk with mentors, talk with your partners, in the lab over consult vascular surgery in the lab over anything that you need. Take that second to think about what to do next. As a new attending now, one of the biggest things when I was looking for a job is trying to find partners that I trusted and that I felt like were available and there for me, because I know what I'm doing, but sometimes you just need that reassurance that you do know what you're doing. And I've had a couple STEMIs during the day now, and my partners have popped their heads in several times while I'm in there because they know I'm doing a STEMI to see if I need anything. One of them came in and was like, "So, you think maybe we should consult CV surgery? Because it was a trill vessel disease patient, STEMI, but the RCA was recanalized, the ST segments were down." I was like, "Yeah, actually, that's a good idea." I had the wire in hand ready to wire the lesion and stent it. And he's like, "Maybe we should do CV surgery." I was like, "Yeah, that's a great idea, actually." So even, with decision making and with complications, lean on each other, lean on your partners, lean on fellows, even as an attending, ask people for their ideas, staff, everybody can kind of help guide, obviously, to the decision. But
I think it's important to know that everyone in the room, when there's a complication, is looking at you, and everybody takes their cues from you. And so if you are anxious, nervous, yelling, or not organized, people get very anxious and yelling and disorganized as well. And I think that taking a deep breath, knowing that everybody is sort of waiting for your guidance, and then taking that step and making those decisions and continuing to move forward, like trusting your intuition, trusting your gut, knowing that you have the skills to take care of a complication at the time. And then if you have a chance, if I always try to go to the patient and touch base with the patient and say to the patient, "I know this is scary. There's fluid around your heart, or there's a complication. We are going to take care of it. You are going to be okay. We are doing everything that we can." And then debriefing with your staff afterwards, letting everybody know that they did a good job, that it's very important that they're all part of the team, that every complication, everything that happens in that lab is dependent on the team that's there, or in the ICU, or wherever the complication takes place. And then if in the situation that there's a bad outcome, I think going to the family, sitting with the family, being as honest as you can with the family, and just making sure they know that you are there to answer any questions for them as much as they need, as often as they need, until they're comfortable, I think is really, really important. It's terrible, and with dealing with life and death all the time. When we make a mistake, I always say, like, when your nail person makes a mistake, you have a hangnail, but when we make a mistake, somebody dies, and is never easy. And letting your patients know that you understand the severity of the decisions that you make, I think, is always really important.
I think those are great points. The one thing I'd like to add, Dr. Mishra, in this happens to me when a complication is happening in our mind, we have to make decisions very quickly, but we have time. So for instance, if there's a pericardial effusion, someone is prepping the chest. That's going to give you 30 seconds, and 30 seconds can be a lot of time in a complication. So if you just calm, and along the lines of meditation, if you just take a deep breath, calm down in your mind, think through the steps before you just speak out what's on your mind, it calms the staff down. It helps you think through more clearly, and I think you do a better job overall. So it's important to be on your feet, but you don't have to make decisions in seconds. You have more than seconds to make a decision. Were there any other questions from the group? Did you guys have anything else to add? That was amazing. I learned so much from each of you, and it's a very tough topic. So I'm very grateful y'all were so honest and upfront about your experiences.
No, this was amazing. Thank you for inviting me.
Thank you. Thank you so much.
Yeah. Well, thank you again. Have a great night, everyone.